spending less money in healthcare on elderly care is not necessarily a bad thing. And then the robot goes into the room and forces the old lady to drink something else. That's one of the biggest problems, I think, in Germany. In healthcare, you don't really have a customer. Germany has this reputation of being terribly slow. Then the nurse has time to hold my hand and ask me how my day was. Who are you creating value for? If you stand up at work regularly, this has a high impact on your overall survival. Evidence is the only currency that counts in Germany for health.
Hi everyone, this is our new episode of Digital Health Interviews. I'd like to introduce our today's guest. His name is Jonas Albert. Hi Jonas.
Hi, how's it going? Glad to be here.
How are you?
Reasonably fine, as always.
Tell us a little bit about yourself and how are you involved in digital health?
Sure. So at my current position, I work as a consultant in a consulting firm that is heavily specialized on digital health. So the whole continuum of digital health, we consult almost every stakeholder in the ecosystem. So we consult the Federal Ministry of Health, federal institutes that are also involved in delivering or at least regulatory approval of healthcare. We consult health insurers, statutory health insurers mainly, the biggest group in Germany. But we also, and that's the part of our area of activities that I'm mostly focusing on, we also consult industry players who produce, manufacture, provide services, products in the area of digital health. Obviously, especially regarding the latter area, digital therapeutics reimbursement in Germany is a thing, so there has been a huge uptake in that activity, and that has also been the focus of my activity of the last 2 years, how to get digital health innovation into reimbursement.
Very interesting. We'll definitely talk more about your job a little bit later, but since you're our first guest from Germany, you have an important mission to give us a very brief introduction, I would say, into German healthcare system.
Yeah, sure. Okay, wow, that's a big task. And there are probably people that can do this much better than I ever could. But overall, I think to start in explaining what the German healthcare system or the ecosystem is all about, I think the most important thing is to understand statutory health insurance and the self-governing structure of the German system. So we have two generic healthcare system archetypes in the world. They're called the beverage system, that would be like the National Health Services in the UK, or the Bismarckian system. Obviously, Bismarck, Otto von Bismarck, the father of insurance or worker or health insurance in general, but that's our system until today. So we have statutory health insurance and we have 100% insurance coverage. 90% are in the statutory health insurance system and 10% are in the opt-out system. They are privately insured. So that's a big difference to other markets or environments where private insurance plays a higher role. In Germany, really the vast majority of insured people, and these are over 60 million at the moment, 60 that is, and they are in the public coverage system. Another peculiarity about the German healthcare system is that we have a big focus on outpatient care, but not like, for example, in Italy or, for example, in Spain with these ambulatory centers. We have single doctors or a small amount of doctors, 3, 4, working in what we call a private practice, although it's not private, it's just privately owned by the physician, but they treat publicly insured patients, almost all of them. Same thing with the hospitals. We have a very small private inpatient sector. Just 15% of the hospitals are privately owned. And the rest basically is half and half owned by either public entities, for example, cities, and the other half is owned by non-profit entities. Of course, I could go more into detail, but as an overview, I think that's enough. The most important thing to say about Germany is that the out-of-pocket spending due to the system of healthcare is quite low, and also that the Federal Association of Public Health Doctors and the Federal Association of Public Statutory Health Insurance, they are an organ, like a public stakeholder that exists independently from the Federal Ministry of Health, and they decide together mainly what gets reimbursed. There are exceptions, for example, regarding the new digital health legislation, we'll surely talk about later. But in general, this Selbstverwaltung, that's the German word, self-governance, so not like a top-down system, like, for example, in the UK. In the German system, the Federal Ministry of Health sets the rule set, but the actors have a high level of independency, which in combination with a very strict catalog of what to reimburse and what not, that's a very interesting playing field. but that also makes the market extremely relevant as soon as you actually manage to get in.
Since you know a lot about other European countries' healthcare systems, would you consider the German healthcare system effective?
Well, effective is always a strong word. I don't think there's any healthcare system in the world that's effective currently. In some ways, Germany is extremely effective. Like, for example, we have very short waiting times. I mean, I know German citizens will say that's a joke. We have long waiting times, but compared to some other countries, we have very short waiting times for example, radiological exams, so like CT scans, for example, MRI, so to speak. And we have an absolutely insane amount of hospital beds. Like ridiculous when you think per capita. But then is that effective? I don't know. Like you have effective treatment, you have a very high level of quality in terms of treatment, but cost effective? Probably not, because our spending per capita is quite high. But on the other hand, we have almost no catastrophic out-of-pocket spending, which, for example, countries like the US have an insane amount of. And so I think by comparison to our European neighbors, we have a very good and reliable system. We are just very prone, because our healthcare contributions are not tax-based, but they are contribution-based based on your wage, and people with high incomes can opt out. And so in that case, you are even more vulnerable to an aging population. That's also why cost containment for that is very similar to, for example, Japan is in Germany also should be priority number one to have like good care for the elderly, but with a big focus on cost effectiveness.
Interesting. I have this point that there's...
Oh, sorry.
No, that's good. But 22% of the population are older than 65 right now.
Biggest problem, exactly.
It's like the second after Japan.
Exactly, yeah. That's why I said Japan is the only one that is worse off than us, basically.
Okay, we'll get a little bit more about the trends a little bit later. But now I think it's a good moment to dig into digital health in Germany.
Sure.
Of course, lots of people think about the fairly new reimbursement system that is working right now. Can you please tell us a little bit about DiGA and what it is?
Yeah, sure. So DiGA, in the most basic sense, is a pathway to obtain public health or public health insurance reimbursement for a digital therapeutic. And digital therapeutics, that's a newer term. There's a DTX Alliance, and like in the last 5 to 8 years, this term really became a bit more mature and more prominent. But what it means essentially is that you have a software-driven thing. It can be software itself, it can be hardware in combination with software, that creates a health-relevant or health process-relevant benefit by itself. So digital drug is the closest equivalent, if we don't want to call it digital therapeutics, that we could use. And that's really revolutionary, because when we think about digital health, many people still use like more old-fashioned words, like telemedicine is like the oldest, which is a part of digital health. And then there's also e-health, which we usually now more use either for electronic communication, it's for example text-based, or for electronic health records, patient records, and so on. But digital health is really the umbrella term, with telemedicine, e-health, and digital therapeutics as 3 of the main columns. There can be more, of course, always nomenclature. But then again, this digital therapeutics that you have, for example, a smartphone app or a web application that gives you instructions, maybe in combination with a wearable sensor, for example, or without it, and you following these instructions, changing your behavior or performing actions, exercises, and that actively impacting your health. Not on a primary prevention, or maybe in 10 years, no, now. Like within months, basically. And that's really revolutionary, because Europe is the only country in the world where such a thing has a clear and dedicated reimbursement pathway. Like you have the same certainty like when you develop a drug. If I go over these hurdles, if I do this, I will get reimbursed. And as I said previously, then you're in on 90% of the insured population in Germany, which is also crazy when you think about it.
So, if I understand correctly, and I think you said that, it can be either a medical device together with a software, some kind of application, or just an application itself.
The software and the majority of all the DiGAs currently are smartphone applications, they're smartphone apps. But the software itself has to be medically certified. They have to be medical devices according to the MDR. However, with a limit, the medical device can't go beyond risk class 2A. Yeah, but they can interact with sensors, or they could theoretically interact with a pacemaker, so something that has a significantly higher risk class. But then the app would be the DiGA, And then the other hardware would be then a necessary companion product or something like this. Obviously not a pacemaker as a companion to a DiGA. That's like people get the pacemaker, and then when you have this pacemaker, you would be eligible to have a DiGA that helps you deal with having a pacemaker, for example.
Mm-hmm. Can you give some examples, not necessarily names of the applications, but what they do that already approved?
There's a very broad range of them. I mean, people say that's only 34, but for such a new process, I'm actually amazed how fast this went, because Germany has this reputation of being terribly slow for everything regarding to digital health, and then suddenly, bang, new legislation, a different stakeholder, like the Federal Ministry for Pharmaceutical Safety took over the process, and now you're in charge. You're in charge for this process, and they just went with it. And like, I'm really surprised that, and especially that such a broad, like such many different DiGAs were actually listed. Because in the beginning, everybody thought, okay, the first DiGA will just be like a blood sugar monitor, but it wasn't. The first couple of DiGAs were actually cognitive behavioral therapy, but app-driven. So, for example, you wait on psychotherapy, but you can already get a therapeutic intervention for example, depression or anxiety, panic disorders on your phone. And they also found out that some patients use this to go over the waiting time, but also other patients say, I find this much easier to do with my phone than with a face-to-face contact with a therapist, or to have the first step, and then I'm only able then to actually go to therapy later because I had this ease in the initial process. But of course, all DiGAs have to work by themselves, so they have to work without psychotherapy in this case. So psychotherapeutic apps using cognitive behavior therapy, that would be one example. Another example is very simple: weight loss. Like, you have patients that are obese, and you see what exercises can they still do with their condition. Very closely monitored nutrition counseling, like not only input but also log your meals. And also with regular outputs for the doctor, so that the doctor stays in the loop. But then there are also significantly more complex ones, like, for example, exercise regimen for erectile dysfunction, for example, like really more complex issues. Or we have companion DiGAs for diabetics that have an insulin pen, and then how to deal with that. And there are a lot of breast cancer. Specific DiGAs that support patients on their journey through their breast cancer treatment. And then some of them target quality of life, some of them reduce pain. Obviously, a lot of back exercise DiGAs, musculoskeletal pain. It's kind of a digital physiotherapist at home almost. Interesting. Broad range.
I know this question might be obvious for some people, but I really want to make sure that our viewers understand the whole process. So let's imagine a patient comes to a doctor with some chronic disease, for instance, and the doctor decides, okay, this approved application specifically can help this patient. And what happens next? The patient just uploads it from Google Play, Apple Store. Who pays for it, or how does that work?
So it's very similar, like to having a drug prescribed, except that the pharmacy is the Play Store or the Google Store or Apple Store, or however you want to call it. Or you can also just download it from any public net, basically, in the end. So you go to a doctor, and they have the DiGA also in the list. They have a pharmaceutical register number, like a drug, basically. And then they select it. It has inclusion and exclusion criteria, which patients are eligible, for which patients is there evidence. And so the doctor has, like a drug, very specific instructions under which circumstances this is beneficial for a patient. And then the doctor, the physician, also has to see, okay, does this fit in the current treatment regimen? Like, does this fit with the other drugs the patient is taking? Does this fit at the moment? Is the patient willing to have such an application? And then they get, and that's really funny, we work on an e-prescription in Germany, and it's slowly coming, but the DiGAs are still prescribed on paper. Muster 16, I think it's called. Like, template 16 is then filled out by hand, and the patient gets instruction, hey, that's the name of the DiGA, you can already download it in the App Store, but you have to hand in this prescription form, this paper form, to your health insurance, and then the health insurance will generate a unlock code that the patient will then receive. And there are a million ways how you can do this. You can even fax this to your health insurance, but you can use the app, take a picture of the prescription and so on. But you could also theoretically bring this in person to a representation, like to an office from your health insurance, and then hand it in. But usually the patient can directly after prescription already download the DiGA, and there's like a 2 weeks initial like, I don't know, courtesy trial, whatever phase, call it how you want. So patients can use it right away after prescription. And then usually it takes just 2 to 3 weeks for the health insurance to process. It should go faster, but they're working on it, I'm sure. And then they get the code, and then they can use the full DiGA from the time. Usually DiGAs are prescribed for 90 days, most of them, but some of them are prescribed lifelong, or some of them are prescribed for more months. But I think this will diversify more in the near future. And then the manufacturer of the DiGA, as soon as they have the unlock code confirmed in their system, there is goes over a specific API. So there's a communication interface between them and a health insurance. Usually there is a billing support provider as an intermediary, and then technically the health insurance pays a one-time fee per prescription, and the confirmation of the prescription is when the patient punches in the correct unlock code.
So there is no, for example, monthly subscription of the app?
No. And it's prohibited. You cannot have anything paid out of pocket within the DiGA. You cannot advertise for anything in there. I mean...
No in-app purchases?
No in-app purchases, definitely not. That's very, very, very strict. I mean, of course, if the DiGA is part of a larger platform, then that's sometimes a bit difficult, because you have to very clearly state to the patient where the DiGA ends. Like, are you leaving the DiGA? Is this something from the same manufacturer, but that's not part of the DiGA? Are you now navigating to a website that's outside of the control of the manufacturer or out of control of the direct DiGA? And of course, for example, it's possible to offer coaching on the side, but that has to come over completely different channels. And DiGAs are subject to the Heilmittelwerbegesetz. So that's anything that's either pharmaceutical or medical device. They have specific laws in Germany, what you can and what you cannot advertise for, and how and where you're allowed to advertise. And DiGAs fall under the same law because they're also medical devices.
Okay. An important question. How does government and insurance company actually understand what kind of value this application brings? Like, they need to make sure, okay, the patient is using the app, we're paying for it, and it needs to bring value. How do they measure it?
Yeah, that's a very interesting question, because a lot of people can't even imagine like what's an app doing, but they are evaluated like pharmaceuticals, exactly the same. Prospective, randomized control trials. Obviously, you can't double blind them because you don't have a placebo, like you can't have a placebo app, but they're compared against care as usual. Yeah, complex statistical analysis will be done, usually lots of subgroup analysis. You have to have a huge amount of confounders, because like a list of confounders, and the BfArM, the Federal Institute for Drugs and Medical Devices, they are governing the process, and they're being extremely strict. In some cases, even stricter than the Joint Federal Committee on their actual methods of enforcing the highest quality of the studies. That's one of our main tasks, basically. We support companies in designing these studies and executing them. And what was it? I think it was 84% of all rejected or withdrawn applications were rejected or withdrawn by the manufacturer due to them not being able to have their evidence requirements on par, because most of them are not used to actually conduct randomized control trials. And there is something to criticize there, because for some interventions, a RCT is not necessarily the best way of generating evidence, but it is the gold standard, and there's a lot of adherence to the gold standard. Yeah. One important thing there is, however, there's no health technology assessment in the sense that there's a cost-benefit thing. So the BfArM, the Federal Institute for Drugs and Medical Devices, they check, does this create value in one of the value categories? So either medical value, increase in survival, increase in quality of life, or of course increase in state of health. So that would be lower pain, more stable blood sugar, etc. Or some other structural or procedural improvements. So lower waiting times, better access to care, higher adherence, increase in health competence, patient empowerment. So individual patient decision making is improved. So, and if you have a validated endpoint that you can prove that this has a significant improvement in a controlled prospective study, and you fit in one of the predefined categories, only then are you allowed to become a DiGA, basically.
Understood. Yeah. What's next for DiGA? I've seen there are plans for DiPA, digital care applications.
Yes. So for DiPA, digital nursing care application, they just cloned the process, but with a with a bit broader approach. So DiGA are really like very specific targeted interventions, and DiPA are more support programs for people receiving nursing care in an ambulatory, in an outpatient setting. So they are at home, they're having one of these, we have degrees of care that are based on how high the impairment for a specific person is. And so if you have this first level or a higher level of need of care, Pflegegrad is the German word, and then you are eligible to have a DiPA, and they're there to support you in regard mobility, cognitive capabilities, self-care, social activities and communication. So all these different parameters that determine whether or not somebody needs care at home or not. And it's basically the same like DiGA with a bit different reimbursement mechanism, but not significantly less lucrative for manufacturers, and also with most likely a bit lower requirements regarding the evidence, because nursing care is such a complex system. You cannot have like these very rigid prospective RCTs. People need different support, and then ambulatory care services involved, so they have to be a bit more open regarding this. But otherwise, it's the same process. Within 3 to 6 months after your application, you know whether you're listed or not, and you're reimbursed ad infinitum basically for these things.
So both these types of applications, they're still related to what we call sick care. And what about prevention care?
Oh yeah, don't get me started. That's one of the biggest problems, I think, in Germany. It's, for example, I mean, technically, DiGAs are also allowed to be there as secondary or tertiary prevention. That's fine. But people need to be diagnosed with something. Or, for example, the nursing apps, the DiPAs, they're also there to prevent somebody in need of care to get worse, right? So that's technically, but it's not primary prevention in the sense that we mean it. And primary prevention, at least according to my humble opinion, surely there are people that see this differently, but I think it's not well paid enough in Germany in order to really have companies with high innovation power focus this sector, because it's mainly courses, it's very established, and they're really, I think in primary prevention there needs to really be a new movement that you have some population health parameters or anything, because currently, I mean, for example, I did a nutrition program for weight loss. I said, hey, I want to lose a little bit of weight. I think I eat very unhealthily. I mean, being a consultant, what do you expect? But then basically you have a 6 weeks course. And it was already digitally supported with an app. It was not a DiGA, because DiGAs cannot serve primary prevention. That's excluded because it's a different financing mechanism. And then you have 6 weeks course, and like a nutrition counselor calls you regularly, and you take pictures of your food. And I think it was like then 200 euros, but that's it. I would not be eligible to do this again in general. I mean, there are exceptions. So primary prevention should be a bigger focus, but the problem is a lot of companies push for primary prevention, but they also have no way of proving it. So it's a bit buzzwordy. So I can understand the skepticism from the payer side, because, well, if we would reimburse everything that sells primary prevention, I don't know, I heard lately a study where somebody said, like, and it was a proper scientific study, if you stand up at work regularly, this has a high impact on your overall survival of like 8 years. And of course the study says that, but probably the situation is more complex than this, right? And then if you would not reimburse somebody who tells people to stand up the same amount of money that you would reimburse a drug that prolongs survival by 8 years or something, right? There needs to be more plausibility for primary prevention, and creating a process there, how to prove it or how to approve it, I think that would be absolutely fantastic. And I think opening up DiGAs for primary prevention might also be a good idea, but then we have to change the evidence requirements.
Let's get back a little bit about digital health trends. We've talked a little bit about the elderly people. Do you think there's gonna some kind of trend? People are gonna develop more solutions for elderly people because of that stats?
Yeah.
Or any other trends you can?
I think in general the trend is really also regarding the economic situation at the moment. Maybe like first one level higher, where is innovation coming from in healthcare systems? Because the state is not very innovative at the moment. We really see this, except this legislation. That was crazy. And I will never forget, I was not the biggest fan of the health minister, Jens Spahn, but for this legislation, chapeau, I will always respect that. That was really, really crazy. Crazy good. Also very experimental. Let's do first and then see how it happens and develops. It was great. But who is actually building the innovation? And the first line in Germany is always venture capital financed startups. Then the Mittelstand, the SMEs come in and do some joint ventures, maybe with one smaller company or with like lots of satellites of consultants and service companies. And then big pharma comes in afterwards. And that's also the development that we're currently seeing. So the SMEs are slowly starting and pharma is looking at it. But the first line is, and venture capital needs a specific environment to work. On the other hand, venture capital was also very hesitant regarding should we really invest, and the reimbursement process is so long. They all came from tech investment and their sales cycles are different. The development cycles are different. They don't have this, well, now it takes us 1.5 years to just gain market access. They were not used to that. But now that out-of-pocket spending for apps or for lifestyle, especially in Europe, because we actually have a healthcare system and not this abusive thing that the US call a healthcare system, the willingness to spend out of pocket is so much lower here. And now that all the inflation goes up and all the other prices go up, the spending for this goes down. And more companies say, oh wow, if I have reimbursement, this is crisis stable. The insurance will not lower their reimbursement rates because of the economic situation, and they will always get saved by the state, even if wages go down. I mean, and that's really a thing that's now just coming. And the more we harmonize it in Europe, the more reimbursement options we have. If you're reimbursed in this country, it's easier to go to this and that. For example, France is copying the fast track. I think that will be one trend, to have more invest in reimbursement-driven business models in the European healthcare sphere. And then for the elderly, definitely, because we have to do something. But I think that for the elderly, it will be more, you can have this super triple win for this. You can have something where a manufacturer is making good revenue, a lot of return on investment, where elderly people can stay at home longer and be more independent. And the third thing is that because they stay at home longer, the healthcare system or the social security, the social insurance system actually has lower amounts of spending because people do something they want. Because that's also one thing that people don't understand. Spending less money in healthcare and elderly care is not necessarily a bad thing. I don't want a colonoscopy. That's very unpleasant. I would rather have an app or any other thing that gets me to a situation where I don't need to have one in the first place. And then everyone's happy. And I mean, and we also don't have like payment systems for hospital and stuff that they force like these treatments on you. And that's also not necessary. One thing I always found very interesting, I talked a lot about robotics where I worked previously for the elderly. Mm-hmm. So this can be very easy, and like animatronics, like entertainment or whatever, or also conversation practicing regularly with a robot. But one thing was very easy. You have a wearable, it shows you if someone is hydrated, and then a robot comes to your room and gives you a bottle of water. Very easy, not high tech. And then I was presenting this just as an idea, as an example, and then this one person stood up and said, and then the robot goes into the room and forces the old lady to drink something. I was like, what? Where is this coming from? Like, if you could construct such a robot, that would be amazing in robotics. Ethically very questionable, but still, it's. We always think about the Terminator, because like movies and like all these dystopian future scenarios have indoctrinated us. But when I think of a robot in a home for elderly or at home, I think of a smart toilet that allows you to wipe your own butt or don't have anybody do it for you. And that's the thing when we talk about digitization or robotics or whatever for elderly care, we always talk about, the human factor is lost. No, the human factor is gained. If I can push a button and a robot wipes my butt or whatever, then the nurse has time to hold my hand and ask me how my day was. And that's what we should go for. And I think slowly people are realizing this, that more human time and more digitization actually goes hand in hand, and it's not opposites, basically. And I really hope that this is becoming a trend, and nobody builds robots to force people to drink something.
I wanted to get back to what you do. And since our target audience mostly is startup founders in digital health, can you give us an example of how you do the research and how do you suggest some business model for startups?
Yeah. So obviously I'm a little bit biased in that regard, because I think reimbursement-based business models are really the next big thing, what we recommend, but that's also what we focus on. So for example, the first thing we ask potential founders or even people with already existing startups or products, we ask them, okay, who are you creating value for? So the standard value proposition, although not the Osterwalder canvas. I wrote a whole paper why the Osterwalder canvas is not very well suited to digital health business models. Look it up. Why digital health business modeling, why classic business modeling approaches don't work for complex domains. At the example of digital health, Jonas Albert and Thomas van der Auermoll. No, this was a conference paper from 2017 or something. Okay. And what we usually do at the start is who do you create value for, and what business models in terms of who are you planning to be your payer to be. Because the thing is, in healthcare, you don't really have a customer, except for the B2C out-of-pocket business models. And for the classic B2C models, we always say, hey, you're a lifestyle intervention, that's fine if you want to do that, but then other people can do this better than us. So we always start at the point where somebody says, I want to be somehow embedded in the healthcare system, I would like reimbursement, or I have this product, how would this have to look like in order to be reimbursed? And then we identify the different reimbursement channels. So obviously DiGA, DiPA is always a thing, but also there are selective contracts. There are the method assessments by the Federal Joint Committee and like lots of others, medical device, how do you get this into a practice and so on. And then from the start, we either do two things. We either have an existing product and look what matches best, or we have a product concept, an idea, a target group, a mechanism by which it works. And then we delineate the best strategy to develop this product towards the most lucrative channel for this specific area. And then from there, we support them the complete way until they either have a contract with a health insurer, or if they're listed as a DiGA, or if they're deployed in a hospital. And the way in between usually involves, and that's where our biggest expertise lies, two things. One is, how do I generate the evidence that the respective stakeholder needs in order to get me reimbursement? So what study or what indicators do I need for a health insurance to have a selective contract with me? What study do I need to become a DiGA? And also, or for example, what criteria do I have to fulfill that the hospital would purchase me as a medical device if I'm equivalent to something else? Lots of options there. And so the whole product strategy and evidence generation is intertwined. And that's really what we're mainly offering, like to have the full strategy to how to go to the German market. What do I need in terms of studies to conduct in Germany, or can I use other studies? And then in the end, what price, of course, can I derive from this evidence? Although that's like almost a bracket over everything, because in the beginning for the product design, you think about how much will the evidence cost, how long will it take, and in what price will it result? And then in the end, you check again, okay, with now the evidence I actually have, what price can I really ask for? And that's always the thing you have to ask. Evidence is the only currency that counts in Germany for health. Yeah. And that's of course, I could talk hours longer about the whole process that we support, but these are the big points that we help with, basically.
Do startups usually come at that very early stage to you, or
completely different? Mm-hmm. Sometimes sometimes it's so early that but what do you actually do? Yeah, something with blood, I don't know. And it's like, okay, well, fair enough. And then sometimes they come, we have this product, it's completely validated, and then but it doesn't really work. Like, you should have asked us like half a year ago. But it's also nice because we're used to everything. So any stage is fine. And sometimes we say, hey, this product can pivot, or maybe you copy paste the product and then change it a bit, or maybe we just look for existing revenue channels, reimbursement channels for this very specific product. But what we also do more and more, and that's for startups and for bigger clients, is to work on a product portfolio strategy. What should I develop? How should I develop it? Or I have these types of software, what can I do with them? And then roadmap for the next couple of years and so on. Yeah, we also now join forces with a bigger service provider in that regard, so we can also have completely outsourced development on our side, and also CE marking, everything. We have CROs in our hands, so we do this when bigger SMEs come to us and say, I have a high expertise in, I don't know, orthopedic, I don't know, prosthesis or something like this. I want a DiGA in this area, and then we just do it completely for them. That would be the one extreme, and the other extreme would be just being a helpline for startups during the DiGA process. That's like the minimum thing, basically. Yeah.
Okay, then my last question, it's not really a question, would work perfectly for you with all your experience. Could you please give any recommendations or piece of advice for startup founders in digital health?
No. So always before you go to German market, do a PICO or a PICO-S. Patient intervention, control, outcome, study design with your own product. Imagine always, you develop all these claims and all these pitches, and we're saving the world, and it's so important, and we're saving all these costs. But please, please, please think about just you and your team together maybe a couple of glasses of wine, that helps. How would I put my product in a study, and would this really work? Do the reality check. You don't have to do this to the outside, but just with yourself. If somebody would ask me, okay, you have awesome claims, now prove it. In a study that's maximum 1 year or 2 years, I don't know, depends on your timeline, your investors, whatever, but like that's usually the time frame that you should go for. And then if you see like, I can't really quantify what I'm doing, then you might be on the wrong path towards sustainable health business models in Germany. Because evidence is your currency, and if you don't even have an idea how to generate it, and then really look for what your product is actually doing, because marketing in B2C business models suggests value that then patients or buyers, customers in this case, experience themselves later and kind of self-validate it, and they keep on subscribing. But here you have to convince a payer upfront in order to greenlight an enabler to prescribe something to a user. That's called decoupled value creation, or decoupled revenue creation even. And so you have the enabler, the prescriber, the doctor, has to play along, has to be convinced. Almost no financial incentive to do it, no matter the business model. The payer doesn't care about anything except their own parameters according to which they approve it. And the user has to also use it, but the user doesn't have to like it in a way that they buy it, but that they continuously use it. And that's so vastly different from any other tech product development, that really focusing on how do I gain the evidence, and then subsequently, how do I have all these stakeholders aligned in a way that they all fulfill their role, which is really far away from the B2B or the classic B2C business model. So yeah, if you take these things into account, you are really ahead of the pack in terms of your preparation for going to market in Germany.
Thank you. Yeah. This is great. If you have any questions left about German healthcare system, digital health in Germany, or you need some consultancy from Jonas, shoot us an email or post comments under this video. And of course, subscribe to our channel. So thank you, Jonas.
Thank you very much. It was a great pleasure.